early antibiotic administration for sepsis. The purpose of this project is to reduce sepsis bundle failures with a focus on antibiotic administration. Sepsis is a life-threatening organ dysfunction related to the body's response to a microbial infection causing systemic inflammation. Timely intervention with appropriate broad-spectrum antibiotics within 1 hour of diagnosis is linked to improved outcomes, including hospital survival, the reversal of organ failure, and decreased hospital length of stay. Effective treatment of the source of infection is key to sepsis recovery and preventing septic shock. For every hour delay in antibiotics for patients in septic shock, there is a 7.5 to 10% increase in mortality. According to the Centers for Medicare and Medicaid Services, sepsis core measures focus on adults 18 years and older diagnosed with severe sepsis or septic shock. CMS core measures consist of several components including lactate measurement, blood cultures, volume status, fluid resuscitation, broad-spectrum antibiotics, and reassessment of volume status and tissue perfusion. These measures should be performed within 1 hour of diagnosis. The evidence for these components are related to a reduction in hospital mortality and decrease in hospital stay and costs of care. When compliance rates reach 52% or higher, mortality rates improve over 20%, showing a direct correlation between sepsis bundle compliance and decreased mortality rates. Learning outcomes for this project are to verbalize understanding of sepsis and septic shock criteria, explain and demonstrate treatment of sepsis and septic shock using the Surviving Sepsis Campaign 2019 updated bundle, identify risk factors for sepsis, and understand costs related to yearly sepsis diagnoses. Sepsis or septic shock criteria are symptoms related to infectious source such as a cough, dyspnea, purulent exudate with hypotension, fever, tachycardia, tachypnea, and signs of end organ perfusion. The two most used scoring systems to identify sepsis is the Quick Sequential Organ Failure Assessment, or QSOFA, and NEWS. QSOFA is a simple scoring system using respiratory rate greater than 22, altered mental status, and systolic blood pressure less than 100. Each of these is scored with 1 point, and a score of 2 or more indicates possible organ dysfunction and should lead to further investigation. NEWS is an aggregate scoring system derived from 6 physiologic parameters with 1 point for each parameter. They include respiratory rate greater than 22, oxygen saturation less than 90, systolic blood pressure less than 100, pulse rate greater than 100, level of consciousness or new onset confusion, and fever. This aggregate score represents the risk of death from sepsis and helps indicate response urgency. 0 to 4 equals a low risk, 5 to 6 is a medium risk, and 7 or higher is high risk. The PICO question related to this project is formed and is: in the adult emergency department sepsis patient admitted for in-hospital treatment, does provider education improve times to appropriate broad-spectrum antibiotic administration within 1 hour of diagnosis compared to delayed administration after a sepsis diagnosis? The project used the ARC model, which was originally conceptualized by Bernadette Melnick in 1999 as part of a research strategic planning initiative involving faculty from the University of Rochester School of Nursing and School of Medicine in an effort to more fully integrate research and clinical practice, as well as to advance evidence-based practice within an academic medical center and progressive healthcare community. A central concept in the ARC model is that of an evidence-based practice mentor, an advanced practice nurse with an in-depth knowledge of EBP and clinical knowledge and skills who provides mentorship in evidence-based practice and facilitates improvement in clinical care and patient outcomes through EBP implementation and outcomes management projects. Since its original conceptualization, Melnick and Finite Overholt have expanded the ARC model to include multiple strategies for advancing evidence-based practice within healthcare organizations, since specific goals of the ARC model include promoting EBP among both advanced practice and staff nurses locally and nationally, establishing a cadre of EBP mentors to facilitate evidence-based practice in healthcare organizations, disseminating and facilitating use of best evidence from well-designed studies to advance in an evidence-based approach to clinical care, conducting an annual national EBP conference, and conducting studies to evaluate the effectiveness of the ARC model on the process and outcomes of clinical care, and conducting studies to evaluate the effectiveness of EBP implementation strategies. Sepsis affects healthcare in many ways, including increased healthcare costs, loss of productive life, and patient mortality. Sepsis awareness has become a primary focus of quality improvement initiatives in hospitals worldwide. Understanding sepsis physiology is key to timely diagnosis and treatment. In the United States alone, sepsis-related costs are more than $20 billion per year. The World Health Organization has made sepsis a global health priority in 2017 with a goal to improve sepsis prevention, diagnosis, and management in order to improve patient outcomes. The Surviving Sepsis campaign emphasizes routine screening of likely infected patients to improve identification and early treatment. Another recommendation of the Surviving Sepsis campaign is that hospitals have a quality improvement program that emphasizes early recognition and treatment. This project was designed as a continuous education project. Staff was provided with a one-page handout and a PowerPoint presentation as refresher education on the signs and symptoms of early sepsis and updated sepsis bundle core measures. The handout was also posted in visible areas of the nursing station to provide reminders of the material. This project was implemented at a local southeastern regional hospital using a one-page handout and a PowerPoint presentation to provide continuing education to staff. The education included critical components of core measure sepsis bundle recommended by the Society of Critical Care Management. The COVID-19 pandemic caused multiple delays in the implementation of this project. Issues included the facility not allowing students inside to reduce exposure to the virus, staffing issue due to illness, staff turnover from the use of travel nurses, and the ED director resigning for another position, along with new graduate nurses coming in during a pandemic. The original plan was to implement in late December to early January, but issues as stated above resulted in delayed implementation in March. The first quarter of 2021 resulted in an increase in sepsis bundle failures, likely caused by the issue listed above, as well as a dramatic spike in COVID cases after the holiday season. The following slide shows the increase in failures during the first quarter of 2021. Statistical analysis using a Bayesian Poisson regression model, working with rates per quarter, counting the 4 quarters of 2019, the first 2 quarters of 2020, and the first quarter of 2021, revealed that it is unlikely to see 14 or more occurrences or failures in the following quarters. Further education and research will be required, and the facility already tracks sepsis numbers. They are also committed to the return of full-time staff as the pandemic ends to provide better patient continuity. Continuing sepsis education is a primary focus for the facility. The project was designed for simple continuing education and should be easy to sustain at this facility. Sepsis is a primary focus of continuous quality improvement initiatives worldwide. Efforts to promote sepsis bundles have been associated with improved compliance and decreased hospital mortality. Sepsis is expensive. The average cost of caring for patients with a primary sepsis diagnosis averages $18,700 per patient, while the average Medicare reimbursement is between $7,000 and $12,000. Studies show that early antibiotic administration decreases the risk of complication and decreases hospital length of stay, lowering the costs associated with medical care. When compliance rates reach 52% or higher, mortality rates improve over 20%, showing a direct correlation between sepsis bundle compliance and decreased mortality rates. CMS states that without continuous quality improvement, then compliance rates will decrease over time. Studies show that standard order sets, increased bedside monitoring, and continuing quality improvement feedback can modify provider behavior and reduce hospital mortality rates. Thank you.